Okay, let's dive right into this explainer. Today, we're going to demystify the varied realities of interventional spine and pain procedures. We often think of a trip to the pain clinic as a quick in and out visit, right? But the physiological mechanisms at play beneath the surface are deeply fascinating and, honestly, at times, incredibly intense. Like, consider this. Can a routine pain injection cause both a harmless faint and a catastrophic stroke? It sounds like a medical thriller, I know, but we're really going to see how the stakes in pain management can escalate from an everyday nuisance to a literal life-altering event. It's all about understanding that delicate balance of the human body when we start introducing needles, medications, and devices into the incredibly complex real estate of the spinal cord. So here's our roadmap for today. We'll cover 1. The interventional pain landscape. 2. Vasovagal reactions and prevention. 3. Stimulator device and biologic risks. 4. The aseptic meningitis dilemma. 5. Catastrophic epidural steroid risks. And finally, 6. Guidelines and patient safeguards. Let's get right into it. Section 1. The interventional pain landscape. We'll begin by translating some of that clinical jargon so you can truly grasp what actually happens in the procedure room. Whether we're talking about a simple steroid injection or a highly complex surgical implant, absolutely every procedure carries a unique profile of risks. Patients and providers really have to navigate this together. It's never just a quote-unquote simple poke. We're literally manipulating the nervous system to shut down chronic pain, and that requires an incredible amount of precision and a deep respect for human anatomy. Moving right along to Section 2, Vasovagal reactions and prevention. Here, we're exploring a bit of biological irony, our body's defense mechanism of fainting at the sight or feel of a needle. The crucial point here is that vasovagal reactions happen in 1 to 8% of interventional pain procedures. That makes this a very common, albeit really frightening experience for patients. You might suddenly feel dizzy, flushed, nauseous, or even completely lose consciousness because your heart rate and blood pressure just suddenly drop. Now, what's super interesting is that this risk profile points to a very specific demographic, like who is actually most likely to pass out. Well, the data tells us these reactions are significantly more likely in young men, specifically ages 18 to 35, particularly when their pre-procedure pain score is actually pretty low, under a 5. Oh, and it happens especially during neck or cervical spine procedures compared to injections down in the lower back. It's just a really fascinating quirk of our neurology. So, how do we stop it? First off, continuous monitoring of pulse and blood pressure is an absolute must. Applying ice packs to the neck or giving IV fluids can really help counteract that sudden drop in vascular tone. But here is the most striking data point. If a patient has a history of fainting during these procedures, the data shows that using moderate sedation drops the repeat reaction rate from 23% down to absolute 0. Basically, sedation turns off that hyperactive vagal response entirely. Section 3. Stimulator device and biological risks. As we escalate from simple needles to permanent implants like spinal cord stimulators, the stakes naturally get way higher. It is truly staggering to realize that the overall complication rate for these devices sits between 30% and 40%. When you're implanting hardware directly into the epidural space to intercept pain signals, complications are just kind of an unfortunate reality of the math. But we really need to break those numbers down to understand the full picture. While mechanical issues, like lead migration or a dead battery, are super frustrating and happen up to 22% of the time, they're usually just an annoyance that requires a surgical revision. On the flip side, biological complications like a 2.45% surgical site infection rate or an epidural hematoma pose a much, much greater clinical threat to the patient's well-being. Those require immediate, incredibly aggressive intervention. Which brings us to Section 4, the aseptic meningitis dilemma. Let's step into a true medical mystery that intensivists sometimes face after spinal anesthesia. This clinical case report perfectly frames the diagnostic dilemma. Imagine a 36-year-old patient who goes in for routine knee surgery, gets a bupivacaine spinal block, and a few hours later, they develop a severe headache, start vomiting, and become completely disoriented with a stiff neck. Every single alarm bell in the hospital is ringing for a deadly bacterial infection in the brain. But here's the dilemma. The clinical symptoms and even the super high protein levels in the spinal fluid completely mimic a deadly bacterial meningitis. But it's actually drug-induced aseptic meningitis, or DIAM. That's basically a self-limiting chemical allergic reaction to the anesthetic drug itself. It's proven to be this harmless chemical reaction only when the spinal fluid cultures finally come back negative. The patient recovers completely, but let me tell you, that diagnostic journey is incredibly tense for everyone involved. All right, Section 5, catastrophic epidural steroid risks. Now we have to address the most dramatic and terrifying escalation of risk associated with cervical epidural steroid injections. Look at these two intimidating terms, myelomelia and syringomyelia. To put this simply, the physical volume and pressure from injecting fluid into the epidural space in a patient with a severely stenotic, meaning very tight spinal canal, well, it can literally crush the micro blood vessels. This localized loss of blood flow leads to these devastating structural injuries in the spinal cord itself. Myelomelia is a softening of the cord, and syringomyelia is where fluid-filled cysts actually develop inside the nerve tissue. But the risks can be even more sudden and catastrophic. We can see epidural hematomas, abscesses, or inadvertent injections directly into the spinal cord tissue. Most terrifying of all, if particulate steroid matter is accidentally injected into a vertebral artery in the neck, it can instantly embolize. It travels right up to the brain and causes immediate, catastrophic strokes to the brainstem and cerebellum, resulting in paralysis or, tragically, even death. Which brings us to this highly critical perspective straight from the medical literature. This quote highlights a really frustrating reality for many patients. People are sometimes being subjected to these potentially catastrophic, non-FDA-approved risks simply because an insurance carrier mandates that they try an injection before granting permission for a safer, definitive surgery. It completely reshapes how we view the risk-reward balance when the treatment isn't necessarily even the doctor's first choice. Finally, Section 6, Guidelines and Patient Safeguards. After looking at those terrifying possibilities, let's release a bit of that tension by examining the strict, evidence-based guidelines designed to keep patients safe. The foundation of safety lies in guidelines, like those from OSRA, which ground physicians in core physiological truths. When data isn't perfect, doctors rely on pharmacology. Things like the 10% daily platelet turnover rule, or the 5 half-life principle for clearing drugs from the body. It really takes the guesswork out of the procedure room. So, how does this actually build into actionable practice? Well, by risk stratifying the procedure into high, intermediate, or low risk, and strictly adhering to exact holding times for blood thinners like heparin and Lovenox, physicians can drastically reduce the risk of those catastrophic epidural hematomas we discussed earlier. It is all about precise timing and patience. The crucial takeaway here is that mitigating these risks requires a really comprehensive toolkit. It requires continuous clinical monitoring, following strict ASRA anticoagulation guidelines, utilizing moderate sedation if the patient has a history of fainting, and knowing rapid physical maneuvers, like neck flexion and rotation, to instantly relieve spinal pressure if something feels off during the injection. Ultimately, this explainer leaves us with a critical, heavy question. How do we balance the deep, undeniable necessity to relieve chronic suffering with the rare but terrifying reality of these complications? It urges us all to take a more informed, active role in our medical decision-making, weighing absolutely every option with open eyes. Thanks for exploring this complex topic with me today, and I'll catch you on the next explainer.